Hello everyone! Before we start, make sure to like and subscribe to the channel and leave a comment with where you're from and what time you're watching. That way, YouTube will keep showing you stories just like this one. Now, let's begin. I'm a registered nurse at Memorial Hospital in Portland, Oregon. Or at least, I was until I submitted my resignation 2 weeks ago. You can call me Sarah if you want. Though most people in the ER just called me the night shift nurse during my 15 years there. I've seen everything you can imagine in emergency nursing. Car crashes, heart attacks, overdoses, stabbings, and every kind of trauma the human body can survive or not survive. But what I'm about to tell you about is the one call that made me question everything I thought I knew about medicine and ultimately led me to leave the profession entirely. Memorial Hospital is a Level 1 trauma center serving the greater Portland metropolitan area and surrounding regions. It's a sprawling complex built in the 1980s with a 40-bed emergency department that handles about 85,000 patients per year. During my time there, I worked exclusively night shifts, 7 p.m. to 7 a.m., because I preferred the unpredictability and the types of cases we typically encountered after dark. Night shifts in emergency nursing are a different world entirely. You might have hours of routine cases followed by sudden chaos that tests every skill you've developed over years of practice. The night of March 3, 2023, started like any other Friday evening. It was cold and drizzly, typical Pacific Northwest weather that usually meant a steady stream of patients, but nothing too overwhelming. I had been on shift since 7 p.m., and by 11:30 p.m., we'd seen the usual Friday night crowd. A college student who had fallen downstairs after drinking, an elderly man with chest pain that turned out to be indigestion, and a woman in her 30s who had cut her hand while cooking dinner and needed stitches. I was restocking supplies in the trauma bay when my phone buzzed at 11:47 p.m. The message was from dispatch, and it made my blood run cold in a way that 15 years of emergency nursing never had. The text simply read, "Incoming ambulance, ETA 8 minutes, multiple casualties from residential fire, children involved. Prepare for severe burns and smoke inhalation." I immediately alerted Dr. Jennifer Walsh, our attending physician that night, and began setting up multiple trauma bays with the other nurses on duty. Lisa Rodriguez and Michael Chen were already pulling burn kits and preparing IV fluids when the first ambulance arrived at 11:55 p.m. What we saw when those doors opened still haunts me today. The paramedics wheeled in a family of 4, 2 adults and 2 children, all suffering from severe smoke inhalation and burns of varying degrees. But it was the youngest victim, a little girl who couldn't have been more than 6 years old, that immediately caught my attention. She was unconscious, her small body covered in 2nd and 3rd degree burns, her breathing shallow and labored even with oxygen support. "What do we know about the fire?" Dr. Walsh asked the lead paramedic, Tom Bradley, as we transferred the patients to our trauma beds. "House fire on Maple Street," Tom reported, his voice tight with the kind of stress that comes from working pediatric emergencies. "Family of 4 trapped on the 2nd floor when the staircase collapsed. Neighbors heard screaming around 11:15 p.m. Fire department had to use ladder trucks to get them out through bedroom windows. The little girl, Emma, was found unconscious in a back bedroom. She's been unresponsive since we pulled her from the scene. I began working on Emma immediately, checking her airway, establishing IV access, and monitoring her vital signs while Dr. Walsh assessed the extent of her injuries. The burns covered approximately 60% of her small body, with the most severe damage on her arms, chest, and face. Her oxygen saturation was dangerously low at 78%, and her heart rate was elevated at 145 beats per minute. Most concerning was her neurological status. She showed no response to verbal commands, no reaction to pain stimuli, and her pupils were sluggish to respond to light. "Sarah, get me a pediatric intubation kit," Dr. Walsh ordered. "Her airway is compromised from smoke inhalation, and we need to get her breathing stabilized before we can address the burns." As I prepared the intubation equipment, I couldn't help but notice something that seemed odd about Emma's presentation. While her physical injuries were severe and entirely consistent with being trapped in a house fire, there were small details that didn't quite add up. Her pajamas, what remained burn patterns that seemed of them, showed unusually uniform. The fabric had been destroyed in some areas, but was completely untouched in others, creating a patchwork that didn't match the chaotic, unpredictable nature of fire damage I had seen in previous burn victims. More puzzling was the absence of soot around her nose and mouth. Smoke inhalation victims typically show clear evidence of inhaling smoke and debris, with darkened areas around the airways and soot deposits in the nasal passages. Emma's face, while burned, showed no signs of the characteristic soot patterns that should have been present if she had been breathing smoke for any significant period. Dr. Walsh successfully intubated Emma, and we began the complex process of fluid resuscitation and burn care. The other family members were being treated in adjacent trauma bays, and I could hear the controlled chaos of multiple medical teams working to save lives. Emma's parents were both conscious and asking about their children repeatedly. Her older brother, a boy of about 10, had less severe burns, but was in shock and crying for his sister. "How is she?" Emma's mother, Patricia, called out weakly from the next bed. "Please, how is my baby?" "We're doing everything we can," Dr. Walsh replied, which was the truth, but also the kind of response we give when the situation is too critical to offer false hope. As I continued monitoring Emma's vital signs and adjusting her IV medications, I began to notice more inconsistencies that troubled me. Her blood pressure was remarkably stable for a child with such extensive burns. Severe burn patients typically develop shock rapidly as their bodies lose massive amounts of fluid through damaged skin. Emma's blood pressure readings were 95/55, low but not as low as I would expect for someone with her level of injury. Her laboratory results, when they came back around 1:15 a.m., were even more puzzling. Her carbon monoxide levels, which should have been elevated in a smoke inhalation victim, were completely normal. Her blood gases showed some oxygen deprivation, but not nearly the level of hypoxia I would expect from someone who had been trapped in a smoke-filled room for 20 minutes or more. Most disturbing of all was her lack of response to pain medication. We had administered appropriate doses of morphine for a child her size, but she showed no change in her vital signs or physical responses. It was as if the pain medication wasn't affecting her at all, which could indicate either severe neurological damage or something else entirely. "Dr. Walsh," I said quietly, stepping away from Emma's bedside. "Could I speak with you privately for a moment?" We moved to a corner of the trauma bay where we could talk without being overheard by the family. I explained my observations about the unusual burn patterns, the lack of soot inhalation, the stable vital signs, and the normal carbon monoxide levels. Dr. Walsh listened carefully, her expression growing more concerned as I detailed each inconsistency. She was an experienced emergency physician who had treated dozens of burn victims over her career, and I could see that my observations were raising the same red flags for her that they had for me. "You're right that some things don't add up," she admitted. "But trauma can present in unusual ways, especially in children. Their physiology is different from adults, and sometimes we see presentations that don't fit the typical patterns." That explanation made sense medically, but something deep in my gut told me we were missing something crucial. I had been working with pediatric trauma cases for over a decade, and while children's bodies do respond differently to severe injuries, the combination of inconsistencies I was observing felt deliberate, rather than coincidental. "I want to run some additional tests," Dr. Walsh decided. "Let's get a full toxicology screen, expanded blood chemistry, and I want to speak with the fire department investigator when they arrive." I returned to Emma's bedside and continued my assessment while we waited for the additional lab results. Her condition remained stable, which in itself was remarkable for a child with such extensive burns. I began documenting every detail of her presentation, taking photographs of the burn patterns for the medical record, and noting the exact locations and characteristics of each injury. It was while I was examining the burns on Emma's left arm that I noticed something that made my hands shake as I held my pen. The burn patterns weren't just uniform, they were too precise. The edges of the burned areas were clean and defined, almost as if they had been carefully created rather than caused by the chaotic spread of fire through a house. In my experience, fire damage is random and unpredictable, creating irregular patterns as flames follow air currents, fuel sources, and structural elements. Emma's burns looked more like they had been applied methodically, with clear demarcation lines between damaged and undamaged skin. I had never seen anything like it in 15 years of emergency nursing, and the realization of what this might mean made me feel physically sick. I stepped away from the bed again and found Dr. Walsh reviewing the preliminary toxicology results at the computer terminal. Her face was pale, and I could see the tension in her shoulders as she scrolled through the data. "Sarah, we have a problem," she said quietly. The tox screen shows therapeutic levels of lorazepam and diphenhydramine in her system. Those are sedatives that wouldn't normally be present in a 6-year-old child. Lorazepam is a powerful anti-anxiety medication that's rarely prescribed to children. And diphenhydramine is an antihistamine that can cause severe drowsiness in high doses. The presence of both medications suggested that Emma had been deliberately sedated before the fire occurred. "There's something else," Dr. Walsh continued. "I just spoke with Captain Morrison from the fire department. He's been investigating the scene, and he says the fire appears to have started in multiple locations simultaneously. That's not consistent with an accidental house fire." The implications were becoming clear, and they were more horrifying than any medical emergency I had ever encountered. Emma hadn't been the victim of a tragic accident. She had been deliberately hurt, sedated, and left in a burning house. Someone had tried to murder this little girl and make it look like she'd in a house die fire. "We need to call the police immediately," I said, though my voice barely came out as a whisper. "And we need to contact Child Protective Services." Dr. Walsh nodded grimly. "I'm already on it. Detective Sarah Kim is on her way, and I've notified the hospital social worker. But Sarah, we have to be very careful about how we handle this. If someone tried to kill Emma, they might try again if they realized she survived and could potentially identify them." I looked back at Emma, lying unconscious in the trauma bed, connected to monitors and IV lines, fighting for her life because someone who should have protected her had instead tried to end it. The burns on her small body weren't the result of a tragic accident, but deliberate torture inflicted by someone she trusted. The next few hours became a blur of medical procedures, police interviews, and security protocols. Detective Kim arrived around 2:30 a.m. and began the delicate process of investigating an attempted murder case involving a critically injured child. She interviewed Emma's parents separately, though both were still receiving medical treatment for their own injuries. What emerged from those interviews was a complex family situation that had been deteriorating for months. Emma's father, David, had been struggling with unemployment and increasing alcohol abuse. Her mother, Patricia, had been working 2 jobs to support the family and had recently filed for separation. There had been reports of domestic violence, though no formal charges had ever been filed. The most came when disturbing revelation. Detective Kim interviewed Emma's 10-year-old brother, Jake. Through careful, age-appropriate questioning, Jake revealed that his father had been giving Emma special medicine to help her sleep for the past several weeks. The medicine made Emma very drowsy and difficult to wake up, which Jake had found scary but hadn't known how to report. Jake also told Detective Kim that on the night of the fire, he had seen his father in Emma's room before the smoke started, and that his father had told him to stay in his own room and not come out no matter what he heard. When the smoke began filling the house, Jake had tried to get to Emma's room, but found the door locked from the outside. As I listened to Detective Kim relay this information to Dr. Walsh and me, I felt a rage unlike anything I had ever experienced in my nursing career. Emma's own father had sedated her, locked her in her room, set fire to multiple locations in the house, and then orchestrated his own escape while leaving his 6-year-old daughter to die. "How are the parents' injuries?" Detective Kim asked. "Are they consistent with being trapped in a house fire?" Dr. Walsh pulled up their medical records on her computer. "David has minor burns on his hands and some smoke inhalation, but nothing severe. Patricia has more significant injuries, second-degree burns on her arms and back, and more serious respiratory involvement from smoke inhalation. Her injuries are much more consistent with actually being trapped in the fire." It appeared that David had given himself minor injuries to maintain his cover story, while Patricia had genuinely been trapped and injured in the fire he had set. She was as much a victim as her children, unaware that her husband had tried to murder their daughter and had put the entire family at risk. The medical evidence continued to support our suspicions. Emma's burn patterns, when examined by a forensic specialist who arrived later that morning, showed clear signs of intentional infliction rather than accidental fire damage. The sedatives in her system had been administered in doses that would have kept her unconscious and unable to escape even if she had awakened during the fire. Most heartbreaking of all was the realization that Emma's neurological unresponsiveness wasn't entirely due to smoke inhalation or burn trauma. The high doses of sedatives her father had given her, combined with the oxygen deprivation from the fire, had caused significant brain injury that might have permanent consequences even if she survived her physical injuries. By 6 a.m., David had been arrested and charged with attempted murder, arson, and child endangerment. Patricia, still recovering from her injuries, was devastated to learn what her husband had done to their daughter. Jake was placed in temporary protective custody, while relatives the investigation continued. Emma remained in critical condition, fighting for her life in our pediatric intensive care unit. Her physical injuries were severe enough that her survival was uncertain, and even if she did survive, she would face months of painful recovery, including multiple surgeries, skin grafts, and extensive rehabilitation. The neurological damage from the sedatives and oxygen deprivation meant she might never fully recover her cognitive function. As my shift ended at 7 a.m., I sat in my car in the hospital parking lot and cried harder than I had cried since my first year of nursing. In 15 years of emergency medicine, I had seen people die from accidents, illnesses, and violence. I had comforted families through the worst moments of their lives and had learned to process the emotional toll of working with human suffering. But Emma's case was different. The deliberate, calculated cruelty of what had been done to her shattered something fundamental in my understanding of human nature. The fact that her own father, someone who should have been her protector, had been her, would-be killer, was almost too horrifying to comprehend. I couldn't stop thinking about Emma during the days that followed. Even though I wasn't scheduled to work again until the following Friday, I found myself calling the hospital multiple times each day to check on her condition. The updates were heartbreaking, but showed small signs of progress. She had survived the critical first 72 hours, which was medically encouraging given the severity of her burns and the complications from smoke inhalation. Dr. Walsh kept me informed about the ongoing investigation and Emma's medical status. The forensic evidence continued to build a damning case against David. Fire investigators had found accelerant residue in multiple locations throughout the house, confirming that the fire had been deliberately set. Security cameras from a neighboring business had captured David leaving the house through a back door minutes before the fire department received the first 911 call. Most disturbing of all, police had discovered that David had been researching house fires and burn injuries on his computer for weeks before the incident. His internet search history revealed queries about how quickly fires spread, what temperatures were lethal, and how long someone could survive in a smoke-filled room. He had planned this methodically, calculating exactly how to make Emma's murder look like a tragic accident. The psychological evaluation ordered by the court revealed that David had been struggling with severe depression and financial stress, but also showed signs of narcissistic personality disorder. When faced with the collapse of his marriage and the prospect of paying child support for 2 children, he had apparently decided that eliminating Emma would reduce his financial obligations while generating sympathy as a grieving father who had lost his daughter in a house fire. What made his plan particularly heinous was the way he had used Emma's trust against her. For weeks, he had been giving her what he called special bedtime medicine, telling her it would help her have better dreams. Emma, being 6 years old and trusting her father completely, had taken the sedatives willingly, never knowing that her own parent was preparing to kill her. On my next shift, exactly 1 week after Emma had been brought in, I requested permission to visit her in the pediatric ICU. She was still unconscious, her small body covered in bandages and connected to multiple machines that monitored her vital signs and supported her breathing. The burns on her face had begun to heal, but the scarring would be permanent and extensive. Patricia was sitting beside Emma's bed, holding her daughter's bandaged hand and reading softly from a children's book. When she saw me enter the room, she looked up with eyes that held a mixture of gratitude and profound sadness. "You're Sarah, aren't you?" she said. "Dr. Walsh told me you were one of the nurses who took care of Emma that first night." Thank you for everything you did. I pulled up a chair beside her, unsure of what to say. How do you comfort a mother whose husband tried to murder their child? How do you explain that the person she trusted most in the world had betrayed that trust in the most horrible way imaginable? How are you holding up? I asked, though it was an inadequate question given the circumstances. Patricia was quiet for a long moment, still stroking Emma's hand. I keep replaying everything in my mind, she finally said, looking for signs I missed, things I should have noticed. David had been acting strange for months, but I thought it was just stress from being unemployed. I never imagined he was capable of something like this. She told me that the police had revealed David's internet search history to her as part of the investigation. Learning that her husband had spent weeks planning to murder their daughter while continuing to act like a normal father had been almost as traumatic as the fire itself. The hardest part is that Emma trusted him completely, Patricia continued, her voice breaking. She would run to him when he came home, give him hugs and kisses, tell him about her day at school. And the whole time, he was planning to kill her. How does a parent do that to their own child? I'd been asking myself the same question since that terrible night, and I still didn't have an answer. In my 15 years of emergency nursing, I had seen parents grieve over children lost to accidents, illnesses, and violence. I had witnessed the raw, devastating pain of mothers and fathers who would have given anything to trade places with their injured or dying children. But I had never encountered a case where a parent had deliberately inflicted that kind of suffering on their own child. It challenged everything I thought I understood about the bond between parents and children, about the fundamental human instinct to protect those who depend on us for survival. The doctors say she might wake up soon, Patricia said, changing the subject as if she couldn't bear to think about David's betrayal any longer. Her brain scans show some improvement, and they're reducing the sedation gradually. But they also say there might be permanent damage from the lack of oxygen and the drugs he gave her. I looked at Emma's peaceful face, so small and vulnerable among all the medical equipment. Even if she did wake up, she would face a long and painful recovery. The physical healing from her burns would take months and require multiple surgeries. The psychological trauma of learning that her father had tried to kill her would take years of therapy to process, if it could ever be fully healed at all. 3 days later, Emma began showing signs of consciousness. Her eyes would flutter open occasionally, and she would make small movements with her fingers when stimulated. Patricia called me at home to share the news, her voice filled with cautious hope for the first time since the incident. She squeezed my hand this morning, Patricia told me through tears. The doctor said it might just be a reflex, but I know it was real. She knew I was there. I arranged to visit Emma during my next shift, bringing a small stuffed animal that I hoped might comfort her if she was aware of her surroundings. When I arrived at the pediatric ICU, I found Patricia and Jake sitting beside Emma's bed. Jake was reading to his sister from the same children's book his mother had been reading during my previous visit. Emma's eyes were open, though they seemed unfocused and didn't track movement the way they should have. Her breathing was still supported by a ventilator, but the doctors had reduced the settings to allow her to breathe more on her own. Most encouraging of all, she showed clear responses to voices, turning her head slightly when Patricia or Jake spoke to her. "Hi, Emma," I said softly, approaching her bedside. "My name is Sarah. I'm one of the nurses who took care of you when you first came to the hospital." Emma's eyes moved in my direction, and for just a moment, they seemed to focus on my face. It was a small sign, but in pediatric medicine, small signs can represent enormous progress. Dr. Rebecca Martinez, the pediatric neurologist who had taken over Emma's care, joined us at the bedside. She explained that Emma's neurological responses were encouraging, but that it would be weeks or months before they could fully assess the extent of any permanent damage. Children's brains are remarkably resilient, Dr. Martinez told Patricia. Emma is showing signs of awareness and recognition, which suggests that the core cognitive functions may have been preserved. But we won't know the full extent of her recovery until she's able to communicate more clearly. The conversation was interrupted by a commotion in the hallway. Through the window, I could see several police officers escorting someone in handcuffs toward the elevator. It took me a moment to realize that it was David, being brought to the hospital under guard for what appeared to be a court-ordered visit with Emma. Patricia's face went white when she saw her husband. "What is he doing here?" she asked, her voice tight with panic and rage. Dr. Martinez immediately called hospital security and spoke with the police officers. After a brief discussion, they explained that David's attorney had petitioned the court for a supervised visit with Emma, claiming that seeing his daughter's condition was necessary for his defense preparation. "He's not coming anywhere near her," Patricia declared, positioning herself between Emma's bed and the door. "I don't care what the court says. He tried to murder my daughter, and I won't let him traumatize her any further." Jake, who had been quiet during most of our visit, suddenly began crying. "I don't want to see him," he said through his tears. "I don't want him to hurt Emma again." Yes. The situation quickly escalated as hospital administrators, police officers, attorneys, and Child Protective Services representatives all became involved in determining whether David would be allowed to see Emma. The debate centered on Emma's medical condition and whether a visit from her father might cause additional psychological trauma that could interfere with her recovery. I found myself caught in the middle of this legal and medical dilemma, trying to advocate for Emma's best interests while navigating the complex intersection of criminal law, family rights, and medical ethics. As her nurse, my primary concern was her physical and emotional well-being, but I also understood that the legal system had procedures that needed to be followed. Dr. Martinez made the decision that ultimately resolved the conflict. After examining Emma and assessing her current neurological status, she determined that a visit from David could potentially cause significant setbacks in her recovery. Emma was still in a fragile state of consciousness, and exposure to psychological trauma could interfere with the healing process in her developing brain. From a medical standpoint, Dr. Martinez told the assembled group, "Emma is not stable enough for this type of visit. Her neurological recovery is still in progress, and any additional stress could compromise her healing. I'm recommending that any visitation be postponed until she has reached a more stable condition." David was escorted from the hospital without seeing Emma, though I could see the rage in his eyes as he was led past the pediatric ICU. Even in handcuffs and facing murder charges, he seemed more angry about being denied access to his victim than remorseful about what he had done to her. The incident left everyone shaken, particularly Patricia and Jake. The reality that David might eventually be granted visitation rights, even from prison, was a terrifying prospect for a family still trying to heal from his betrayal. That evening, as I completed my shift and prepared to go home, I couldn't stop thinking about the look in David's eyes when he was denied access to Emma's room. There was something calculating about his expression, something that suggested he wasn't finished with his family despite being in custody. I made a decision that night that would change the course of my nursing career. I couldn't continue working in emergency medicine knowing that cases like Emma's existed in the world. The idea that parents could deliberately harm their children, that people could be so calculating and cruel, had fundamentally altered my ability to trust in human nature. But more than that, Emma's case had shown me that sometimes the most dangerous threats come from the people who are supposed to provide safety and protection. As a nurse, I had always believed that my role was to heal and comfort, to be a source of hope in people's darkest moments. Emma's case taught me that sometimes the darkness runs so deep that healing becomes almost impossible. And that realization was more than I could bear to carry for the rest of my career. I submitted my resignation from Memorial Hospital 3 days later, effective at the end of the month. My supervisor, Janet Morrison, was surprised by my decision and tried to convince me to take a leave of absence instead of permanently leaving the profession. "Sarah, you've been one of our best nurses for 15 years, she said during our meeting in her office. "Cases like Emma's are rare, and they affect all of us deeply. But think about all the good you've done, all the lives you've saved. Don't let one terrible situation end your career in medicine." I understood her perspective, and part of me wanted to believe that I could eventually move past Emma's case and return to normal nursing duties. But every time I walked past the trauma bay where we had first treated her, every time I heard a child crying in the emergency department, I was transported back to that night when I realized that someone had deliberately tried to murder a 6-year-old girl. Emma's case will stay with me forever, a reminder that evil can wear the most trusted faces. 6 months later, I learned she had made a remarkable physical recovery, though the emotional scars may never fully heal. Sometimes protecting your own mental health means walking away from what you love most. If you're struggling with trauma from your work, please reach out for help. Thank you for listening to my story.